A 34-year-old woman, Gravida Barawan, comes to the physician heavy vaginal bleeding because of 3-month history of heavy vaginal bleeding with large clot. The bleeding occurs every 10 days and lasts 7 to 10 days. She is not currently bleeding. Before the bleeding began, she had not had menstrual period for 4 months. She has a history of 6 episodes of amenorrhea, and each lasting for 4 months during the past 2 years. Previous treatment with oral progestin-induced withdrawal bleeding. Her last pap smear 1 year ago showed no abnormality. She currently takes no medication. She is 163 centimeter tall, weight is 86 kg BMI and 33 kg per meter square. Examination showed darkened skin with a velvety texture over the base of the neck, axilla, perineum. Coarse hair is noted over the upper lip and chin. There is no thyromegaly. No discharge is expressed on palpation of the nipple. Central obesity is noted. Coarse hair extends from umbilicus to the pubic area. The pubic hair has diamond-shaped pattern. Which of the following is the most appropriate next step in the management? Ready?
Yes. Endometrial biopsy. The most appropriate next step for this patient is endometrial biopsy. Irregular, unusually heavy, unpredictable bleeding or bleeding not associated with usual premenstrual signs and symptoms like bloating, breast fullness, cramps. Should prompt investigation for pathological causes such as endometrial cancer. Other causes of abnormal uterine bleeding include pregnancy, cervical endometrial polyps, adenomyosis, inflammation or infection of the genital tract, coagulopathy, ovulatory dysfunction, endocrine dysfunctions like prolactin, thyroid disorders. These factors for endometrial cancer include obesity, PCOS, prolonged estrogen exposure, early menarche, late menopause, nulliparity, advanced age. Family history: this patient has obesity and has all the classic signs of PCOS, including oligomenorrhea, chronic anovulation, hirsutism, acanthosis nigricans, drastically increasing her risk of endometrial cancer. Endometrial biopsies is indicated for patients with increased risk of endometrial cancer. With biopsy and imaging, the stage of endometrial cancer is determined and follows TNM staging, tumor nodes metastasis. If the disease is confined to the uterus, surgical excision with hysterectomy and bilateral sulfing node is the first therapy. More advanced disease may require addition of treatment such as chemoimmunotherapy. It's not easy. Measurement of serum progesterone concentration during luteal phase may be used in evaluation and ovulation or infertility. The luteal phase begins immediately following ovulation. During this time, the corpus luteum secretes progesterone to maintain the endometrial lining. The measured progesterone is low, it can suggest that ovulation has not occurred or that there is insufficient progesterone to maintain the endometrium, which will lead to menstruation. Serum progesterone measurement will not identify the underlying cause of heavy irregular menstrual bleeding in this patient. Okay, next.
Okay. A 67-year-old man comes to the physician because of 4-month history of increasingly severe constant epigastric pain. She says that he feels full after eating only small amounts of food. During the past 6 months, he has had a 8.6 kg weight loss. He had osteoarthritis treated with ibuprofen as needed, and 15-year history of type 2 diabetes mellitus treated with insulin. He has smoked 2 packs of cigarette daily for 50 years and drinks 2 beers daily. He is 178 centimeter, 5 feet 10-inch tall, and now weighs 67 kg. BMI is 21 kg per meter square. His pulse is 68 per minute. Respirations are 16 per minute. Blood pressure 160, 138 by 72 millimeter of mercury. Abdominal examination show epigastric tenderness. Rectal examination shows brown stool. Rectal examination shows brown stool. Test of the stool for occult blood is negative. His hemoglobin concentration is 12 gram per deciliter. MCB 70. Which of the following is the most appropriate next step? Ready?
Yes. It is upper endoscopy. Gastric cancer classically typically presents with weight loss, early satiety, the gastric pain. Risk factors for development of gastric cancer include a history of smoking, peptic ulcer. Why does he smoke? Yeah. Peptic ulcer, chronic gastritis, frequent consumption of nitrate containing food, the use of NSAIDs such as ibuprofen as seen in this patient is a common cause of peptic ulcer disease as well. Alcohol use can also induce chronic gastritis. Microcytic anemia is in patients with gastric cancer can be caused by iron deficiency, malnutrition, malabsorption, anemia, chronic disease as a result of chronic inflammation caused by the release of immune inflammatory cytokines. This patient is presenting with several risk factors for gastric cancer like microcytic anemia, weight loss, early satiety, the gastric pain, making it most likely that the most appropriate initial step. Gastric cancer is upper endoscopy with tissue biopsy of any suspicious lesions. Wait, let me see. Why is not the other one? Gastric emptying is nuclear scintigraphy exam that is used to assess the emptying rate of the stomach of either solid or liquid. Nuclear radiotracer is bound to a solid or liquid meal after ingestion. The rate of gastric emptying is plotted over a few hours to assess for inadequate emptying rate. This is used for gastroparesis. Okay. Domino CT, abdominal ultrasound, first line diagnostic examination for evaluation of potential cholecystitis. Characteristic ultrasound, blah blah blah. We'll find. We know. Okay. And upper GI series with water soluble contrast, a small amount, small bowel follow through studies are indicated when structural lesion um, software lesions involving the stomach, small bowel are suspected. It is often used for evaluation of small bowel pathology such as duodenal atresia, malrotation, blah blah blah. Crohn's. Upper GI series will not offer the opportunity to sample tissue biopsy. Okay. Abdominal CT can be helpful in the diagnosis of large organ pathology such as small bowel obstruction, appendicitis, blah blah. Most appropriate okay, got it.
Okay, next.
Mhm.
A study is conducted to compare the safety of primary closure of the colon with temporary colostomy in patients with penetrating injuries of the colon. The study is conducted over 36 months of period in a single institution. All patients between age 18 to 65 admitted with penetrating injuries of the colon are enrolled in the study. They are assigned to one of two study groups depending on which procedure their surgeon choose. Observed until discharge from the hospital. The complication rate for the 38 patients who underwent primary closure of the colon, 14%. The complication rate 37 patients who underwent temporary colostomy, 16%. The authors conclude that primary closure of the colon injuries had the same level of safety as the temporary colostomy in adults. Which of the following raises most concern about this conclusion? Ready?
Yes. The patients groups are not matched. The most obvious issue with the design in this study is the method of assigning patients to study group based on the surgical procedure chosen by the surgeon, a process that lacks matching. Matching is an important process in clinical trial design that is intended to produce an equal balance between the study groups variables that may lead to confounding, and is in so doing limits the risk of confounding. Confounding variables influence both the independent and dependent variables and can lead to false association if the confounding variable is not evenly distributed in both groups. A good study design would proactively identify potential confounders prior to randomization. In the given example, the two study groups are roughly equal size and experience a similar complication rate. However, it's possible that other factors led their surgeons to choose one procedure over the other, which is not corrected for in the study design. It's not the where was it? The study is not double blinded, is incorrect. Blinding is a technique for masking the status of the treatment, experimento, standard care placebo from either the experimenter, physician administering the treatment, or the patient. Um, Blinding is helpful for reducing bias that may result from awareness of the treatment being administered. Single blinding masks the status of the treatment administered to the patient, while double blinding masks both the patient and the treating physician. Some trial designs may not be amenable to double blinding. In this example, it's not possible to mask the surgeon to the method of surgery they are performing. Okay, that's true. Although it would be possible to mask the patient to the method as to the method of surgical repair, resulting in a single blinding. Lack of double blinding is not a concerning feature in this study. Makes sense. Next.
Yes. A 15-month-old boy is admitted to the hospital because of temperature. 2-day history of temperature 39.5 degrees Celsius and swollen red mass on the right side of the neck. Our 1 year history are he has 1 year history of failure to thrive, recurrent suppurative skin infection, 2 prior episodes of lymphadenitis. At the age of the 9 months, he was hospitalized for lung abscess secondary to Staph aureus. He has 3 hospital admission for 2 episodes of staph pneumonia with abscess and 1 episode of osteomyelitis. He currently receives no medication. He is at third percentile for height and fifth percentile for weight. His temperature is 39.5 degrees Celsius, 103.1 degree Fahrenheit, pulse 100 per minute. Regular respiration, 30-minute blood pressure is 105/55. Examination shows no dysmorphic feature. There is a 3 into 4 centimeter erythematous indurated 3 erythematous indurated warm tender nodule on the right side of the neck. No murmurs are heard on cardiac examination. On abdominal examination, the liver is palpated 4 centimeter below the right rostral margin. Which of the following is the most appropriate, likely to confirm the cause of recurrent suppurative infection in this? Ready?
This neutrophil oxidative burst test. This patient um, with recurrent pyogenic infection secondary to catalase positive organism consistent with CGD. CGD results from a defect in nicotinamide adeninic NADPH oxidase complex. NADPH oxidase complex within phagocytes such as neutrophil uses oxygen as a substrate for the generation of oxygen free radicals superoxide diet. Free radical oxygen species subsequently used for the creation of hydrogen peroxide and hypochlorous acid. Activation of these pathway leads to oxidative burst, which results in bacterial death. Efficiency on NADPH oxidase complex renders um, phagocytes incapable of neutralizing catalase positive bacteria, which are capable of neutralizing their own hydrogen peroxide, thus leaving the host cell the host cells without the substance necessary to complete the respiratory burst. Okay. Diagnosis is made by assessing the neutrophil oxidative burst with dehydrorhodamine test or blue tetrazonium reduction test. In the latter test, normal phagocytes use the action of NADPH to reduce nitroblue, which leads to a color change from yellow to blue. Patients with CGD will not show color change. Recurrent pneumonia is the most common presenting infection in patients with this condition. The most common infecting bacteria is Staph Aspergillobucoderia nocardia. Patients with CGD are also at risk of fungal infection like Aspergillus. It's not complete blood count, including leukocyte differential. Yeah. It's useful step in the diagnosis of immunodeficiency that affect leukocyte populations such as Bruton's and Mercury, SCID, acquired neutropenia, HIV infection, leukocyte differential are normal in CGD. Okay, next.
Yes. A 22-year-old white woman, gravity para 1, about 128 weeks of gestation, comes to the office because of itchy rash on her vulva that she first noticed yesterday. 2 days ago, a routine prenatal visit. The patient reported a 2-day history of vaginal discharge, but preparation of the vaginal tissue is closed. Trichomoniasis oral metronidazole was prescribed, which the patient began taking yesterday. Medical history is otherwise unremarkable. She has been taking prenatal vitamins. She is employed as an aide in a veterinary office. Mm, Vital signs are temperature 37.6 degrees above pulse, 60 respiration, 15 blood pressure 120/76, physical examination, vulvar findings show fundal height consistent with the days of gestation. In addition to prescribing treatment for itching, which of the following is the most appropriate?
Ready.
Yes.
She should avoid sharing towels and linens with household contact. She should avoid sharing, as this rash is consistent with tinea cruris infection. Tinea cruris associated with superficial dermatophyte infection. It clinically presents with annular scaly erythematous rash with several clearing involving the groin and associated trichophyton rubrum infection. Other common signs of trichophyton rubrum infection include the feet body scar, microscopic examination of the skin, scraping, with KOH preparation will show branching septate hyphae. In accrues, another dermatophyte infection are commonly treated with topical azole antifungal such as ketoconazole, which inhibit conversion of planosterol to ergosterol in the fungal cell wall. Um, Superficial penile infections are transmissible by contact, so it's recommended that the individual do not share clothing, athletic equipment, footwear, or towels with close contact. It's not she should discontinue metronidazole is incorrect, as this will not improve her trichomoniasis or tinea cruris. Trichomoniasis is caused by protozoa organisms. Trichomoniasis is one of the most common STIs. Patients with acute infection may have purulent malodorous discharge, burning pain, pruritus, dyspareunia. Diagnosis may wet mounts showing motile trichomonas or by positive NAT. Metronidazole is first line treatment of trichomonas. Not used. Metronidazole is not used in the treatment of tinea cruris. Next.
A 77-year-old man is brought to the physician by his wife because of 3-week history of confusion, daytime sleepiness, and frequent falls. He appears lethargic and is irascible. Neurologic examination shows no findings on mental status findings. He is oriented to person but not the place or time. Short-term memory is decreased. Which of the following is the most likely diagnosis? Ready?
Yeah, I guess so. It is subdural head trauma, the use of anticoagulants, physical abuse, alcohol use disorder, age-related cerebral atrophy, and malignancy are all associated with increased risk of developing subdural hematoma. All the patients are at risk for cerebral atrophy, which places traction on bridging cortical veins in this setting. Minor trauma such as falls can result in shearing of the veins leading to hemorrhage. In some cases, subdural hematoma may be large enough to compress adjacent brain parenchyma. Displacement of the cerebral hemisphere can cause neurologic deficits, confusion, lethargy, seizures, inhalation syndrome, signs of increased intracranial pressure. Those symptoms onset may be acute and initially small subdural may grow over time, resulting in gradually progressive symptoms, as in this case. Patients may manifest oculomotor neuroexamination findings such as spastic weakness, hyperreflector, Babinski sign, spastic weakness, or confusion may result in falls, though conversely, an initial fall may have resulted in this patient's subdural hematoma. The intracranial compartment is a fixed space within the rigid skull. Pathologic lesions such as subdural hematoma can result in midline shift and herniation and CNS structure. Herniation of CNS structure is large enough. CT scan of the head is the first step in screening for subdural hematoma. On imaging, subdural appears as a crescent-shaped collection abutting the internal socket of the skull, not bound by suture lines. When mass effect is present, or at least for developing surgical interventions such as decompressive burr holes or craniotomy may be indicated to evacuate the hematoma. It is not multi-infarct dementia. Refers to cognitive impairment caused by cerebrovascular disease, classically causing a step 1 decline in function with each cerebrovascular accident. Subdural hematoma present with acute or subacute confusion that may gradually progress over time, making it more consistent with this patient presentation. It's not peaks or frontotemporal. hmm, Okay. Or frontotemporal dementia is neurodegenerative disorder characterized by atrophy of the frontal and temporal lobes, causing deficits in social behavior, personality, Social behavior and personality along with dementia, whereas cognitive impairment typically progresses over months to years, subdural hematoma is acute or subacute confusion. Deficits in orientation, one of the most common basic cognitive skills, typically occur years in a dementing illness. Okay, next.
Yes. A 27-year-old white woman comes to the physician because of increasing fatigue. For 3 weeks, he has a 5-year history of heavy alcohol use. Currently drinks 10 hours alcohol daily. Over the past year, she over the past year, he has had several episodes of hematemesis associated with melanic stone. Examination shows pulmonary erythema, spider angiomata, mild splenomegaly, hemoglobin 7, blood uh, smear show microcytic hypertrophy increase in number. Which of serum study most likely to show which of the following? Isn't it iron deficiency anemia?
Mm, I don't know. I'm between that and the chronic.
Sorry,
I'm between that and the chronic.
or like
How do you call
anemia of chronic disease?
it? Yeah.
I don't think so.
Okay. Mm,
Okay, okay, I'm coming. 1 minute, please.
okay. Okay.
Okay.
Due to decreased diffusion capacity of oxygen to the alveolar membrane and ventilation perfusion mismatch. Metamine silver or toluene. Mm. Metamine silver or toluidine blue stains selectively stain the cyst walls um, and are used to confirm the diagnosis. The presence of pneumonia caused by pneumocystis indicates that this patient is immunodeficient. Immunodeficiencies can be divided based on the cell type affected. T lymphocytes, B lymphocytes, both T and B lymphocytes and phagocytes. In addition, the organism causing the infection may provide a clue as to what type of cell is deficient. Patients with HIV infection with CD4 T lymphocyte counts below 200 are at risk of developing pneumocystis pneumonia. However, it has become less common following the widespread use of prophylaxis with EMPSMX. Next.
Yes. A 23-year-old woman comes to the student health services because of increasing anxiety about being called on in class for the past 6 weeks. Yesterday, she was worried about being called on. Mm, okay. She says that she has always found it difficult to be the center of the attention and has always avoided situation in which she would have to perform or speak in public. Physical examination shows no abnormality. On mental status examination, she is cooperative, well dressed. She is anxious and fearful. Her thought process is organized. There is no evidence of suicidal ideation. Which of the following is the most appropriate next step? Ready?
One moment. She has social anxiety. Do we give CBT or bupropion necessary? I guess CBT. Okay, ready. CBT in social anxiety disorder refers to excessive fear of scrutiny, embarrassment, or rejection in social and performance situations, leading to significant distress or impair function, class or work abilities. Patients with social anxiety commonly exhibit shyness and performance anxiety. Performance anxiety refers to fear of negative evaluation in situations such as public speaking, and being called on in class, test taking, and sex. CBT and SSRI are first-line treatment for social anxiety. Some patients with social anxiety experience anxiety that is specific to performance situations. So, in the performance-only subtype of social anxiety, CBT is recommended at first line. Though, as needed, anxiety medication like benzos and propranolol are frequently used as well. CBT for social anxiety disorder focus on gradual exposure to fear social situations. It's not bupropion antidepressant medication that is increases synaptic dopamine and norepinephrine. It is commonly used to treat MDD. However, its stimulating effects can cause anxiety as an adverse effect, making it suboptimal choice for this patient with social anxiety. Okay.
Ready? Next.
Mhm.
A 27-year-old woman is brought to the emergency department by her sister because of 3 months history of strange behavior. The sister says the patient intermittently mumbles to herself and has refused to leave the apartment they share. The sister has not seen her eating during this time. Yesterday, the patient disposed of all food in the refrigerator during because she insisted it was not safe to eat. She has no history of serious medical or psychiatric illness, takes no medication. She does not drink alcohol or use illicit drugs. She appears distracted. She is 165 centimeter tall, weight 51 kg, BMI 19 kg per meter square. Physical examination shows no abnormality on mental status. Examination, she describes her mood as okay. She has a flat effect. Her thought process is well organized and goal directed. There is no loosening of association. She refuses to answer when asked if she has an auditory hallucination. Which of the following is the most likely diagnosis?
Hmm. This is weird. Is it schizophrenia or is it MDD?
Ready?
Yes. Schizophrenia. According to DMR, patients with schizophrenia have a history of at least two of the following five symptoms: delusions, like paranoid beliefs about food, hallucinations, disorganized speech, disorganized behavior, like disposing of the full negative symptoms. Many patients also experience prodrome of period of strange behavior and also withdrawal. To meet diagnostic criteria, patients must have functional deficit, not whatever, notional deficits, like not eating or not showering. The total duration of symptoms must exceed 3 months. Sorry, 6 months. She only has three. Weird.
Wait one
So
second.
this patient,
I'm calling you. 1 minute.
okay, no
Okay.
worries. No.
We are on the schizophrenia question.
I was reading, right?
Yes.
Yeah, I was reading. Okay. The total duration of symptoms must exceed 6 months, though this patient sister has only observed strange behavior for 2 months. A prodromal period that was less noticeable is likely as the patient's symptoms of the water aligned with criteria of schizophrenia. Mental status exam commonly shows poor hygiene secondary to negative symptoms and evidence of internal stimulation like speaking to hallucinations rather than to external stimulations, such as other people. Wait, I have to pick up this
Yes,
call.
yes, no problem.
Oh, you right away. I can hear you. Okay, let me finish these questions. Where was that? I think I finished that.
Yes,
Treatment requires, yeah, 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 I think I finished that. Next.
okay. A 67-year-old woman has had recurrent episodes of pain and stiffness in his hands and the knees over the past years. The episodes occur almost daily. The episodes occur almost daily. She has no fever or chills. A photograph of the hands is shown. Which of the following is the most likely diagnosis? Isn't it Heberden and Bouchard's note in the hand?
Mm, I don't know how you can see that, but I cannot see it. But even mm,
Okay.
okay, ready.
Yes.
It is osteoarthritis. Degenerative. Oh, this is cut down. Degenerative osteoarthritis is a non-inflammatory arthropathy that occurs secondary to deterioration of articular cartilage. It typically occurs in all patients and may affect any joint. The hips and knees are commonly affected because of chronic weight bearing, especially in patients with obesity. In the hands, the distal interphalangeal joints is most affected with possible development of firm bony nodes in the distal or interphalangeal joint space known as Heberden and Bouchard nodes, respectively. Osteoarthritis is not associated with infectious inflammatory symptoms and is generally insidious in onset. Patients typically experience chronic pain in a joint that is worse with movement or exertion and improve with rest. Patients often have limited range of motion because of underlying joint space narrowing. Imaging may show joint space narrowing, osteophyte, subchondral disease, or sclerotic change. The first line treatment is with acetaminophen, although only a minority of patients will achieve meaningful relief with this therapy alone. Additional options include NSAIDs, intra-articular injection like steroids, and joint replacement surgery for the severe or refractory cases. Okay. This patient is presented with chronic pain as well as head burden and Bouchard node as seen on photograph without systemic symptoms, making degenerative osteoarthritis the worry. Rheumatoid arthritis inflammatory arthropathy that causes extensive inflammation in synovial tissues. Extensive inflammation in synovial tissue and typically presents with symmetric patterns of arthritis, particularly in the wrist, hands. Also, patients present often present with diffuse systemic symptoms such as fatigue, fever, and also appetite. Common findings of exam of the hand in cases of rheumatoid arthritis include swan neck or boutonniere deformities in the absence of systemic symptoms or findings of swan neck or boutonniere. Huh? In the absence of systemic symptoms or findings of swan neck boutonniere deformities, osteoarthritis is more likely. Okay. Next.
Yes. A 40, a 47-year-old man is admitted to the hospital for repair of a recurrent right inguinal hernia. Recurrent right inguinal hernia. 1 year ago, she underwent bilateral inguinal hernia repair and has hypertension well controlled with atenolol. Cardiopulmonary examination shows no abnormality. There are well healed surgical scar over the Inguinal area bilaterally. The testes are descended and mass is palpated in the right groin on Valsalva maneuver. During the operation, the surgeon operates on the left groin. Which of the following is the most effective process to prevent this type of error in the future?
Ready?
Yes,
Is preoperative marking of the operative site by surgeon and patient. Despite best efforts, surgical reliability remains prone to errors, including performance of incorrect procedures or surgery performed at the wrong site or on the wrong patient. The Joint Commission, blah, 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 wrong, whatever, was developed to reduce such errors and improve surgical reliability. Steps include preoperative verification of patient identity, the procedure to be performed, and the surgical site. The patient should be involved in the verification process whenever possible, and any discrepancies or questions should be addressed. The use of checklists can assist in ensuring and standardized verification process. The surgical site should be marked by the surgeon who will perform the procedure and with the patient's assistance whenever possible. The surgical mask should be both unambiguous and positioned so that it will be visible after the surgical drape is placed. Additionally, a final verification timeout should be performed prior to induction of anesthesia to verify the patient identity, the procedure, and the surgical site. In this instance, surgery was performed on the correct patient, but on the wrong side. This could have prevented by preoperative marking by the surgeon with the patient assistant to confirm the correct site. Next.
yes. A previously healthy 3-year-old boy is brought to the physician by his mother because of 3-week history of foul-smelling progressive diarrhea and gas. He has not had fever. He began attending daycare 2 months ago. Vital signs are within normal limit. Examination showed dry mucous membrane with mild abdominal distension. Which of the following is most likely causal organism?
Ready?
Yes.
Oh, wait, what happened? Oh, right here. Giardia. Giardia is a flagellated parasitic organism or that causes giardiasis. Giardiasis usually occurs through the ingestion of cysts in contaminated water, which then mature into trophozoites in the small bowel. Parasitic overgrowth of the small bowel leads to intestinal malabsorption of fats and carbs. Giardiasis presents with persistent diarrhea that is foul smelling and fatty, as well as abdominal pain, bloating, cramping, and weight loss. This patient has foul smelling diarrhea and gas, making giardiasis the most likely diagnosis. Children and infants more likely than adults to present with dehydration and may experience failure to thrive as a result of malnutrition secondary to malabsorption. Diagnosis is made with stool culture microscopy and stool antigen testing. Light microscopy shows flagellated pear-shaped trophozoid with two large central nuclei and a medial as metronidazole is the first line of treatment. It is not, one moment, I wanted to do D. Where is D? Where is D? Right
Salmonella
here.
enteritis.
Yeah. Salmonella enteritis classically present with mucosal inflammation and invasion leading to a toxic presentation with bloody diarrhea. They didn't say anything else. Okay, treatment. Salmonella enteritis infection causes non-typhoidal. Okay, salmonellosis, a leading cause of foodborne illness. It is contracted by the consumption of raw and undercooked poultry and eggs. Nausea, vomiting, and bloody diarrhea are classic features of salmonellosis. Okay, let me see. Salmonella. enteritis. Oh, inflammatory. Okay, got it. Next.
Yes, a 12-year-old girl is brought to the physician by her mother because of 1 month history of lump in her right breast. The lump is not painful and she has not had a nipple discharge. She has no history of serious illness, taking no medication. She is at 25 percentile for height, 50 percentile for weight, and BMI examination show no axillary but there is 1:1. Smooth rubbery mobile mass beneath the areola in the right breast examination of the left breast shows no abnormality. There are no skin changes on nipple discharge. Breast development is sexual maturity stage 2 on the right and ASMR stage on the left. Pubic hair development ASMR stage. Which of the following is the most appropriate next step in the management?
Hmm, ready?
Yes,
Follow up in 6 months. Puberty is a normal part of adolescent development. In females, puberty usually begins around 8 to 12 years old, with an average onset around 9. Puberty progresses to predictable pattern with variation in the onset of speed of advancement through the development of stage. The sexual maturity ratings, also known as Turner stage, include the sequential changes in pubic hair, breast, and external genitalia. These stages range from 1 indicating pre-puberty to 5 representing full adult development. This patient is presented with SMR stage 2 breast development on the side of the identified mass. The rubbery mobile mass beneath the areola seen in this patient is likely development of breast bud, which is characteristic of stage 2. Because of the finding on physical exam being expected at this patient's stage of development, follow-up exam is the most adequate step in management. It's not ultrasound of the right breast is not indicated in this patient. Ultrasound is often included in the initial diagnostic evaluation in cases when a palpable breast mass is identified when there is concern from malignancy. The finding on this patient physical exam is expected as occurring SMA. Okay, next.
a 42-year-old man comes to the physician because of 6 month history of productive cough productive of thick white mucopurulent sputum. The cough frequently keeps him awake at night. He has not had fever or chills, nor has an unintentional 4.5 kg weight loss during the past 3 years. Each winter during the past year, he has had recurrent episodes of bronchitis. Treated with antibiotic therapy during childhood, he has 4 episodes of double pneumonia. He immigrated from Philippines 10 years ago. He smoked 1/2 pack of cigarettes daily for 5 years but quit 15 years ago. He is not in distress. He is 183 centimeters, 6 feet tall, weight is 68 kg, BMI 20 kg per meter square. His pulse is 68 per minute, respiration 14 per minute, blood pressure 132/81, pulse oximetry on room air show oxygen saturation in 95%. On pulmonary examination, coarse bronchi are based at the left lung base. There is bilateral inspiratory and faint wheezing in both lung base. Cardiac examination shows no abnormality. Chest X-ray shown. Which of the following is the greatest predisposing risk factor in this condition? Ready?
Mhm. This history of first track infection, bronchiectasis. How did they solve bronchiectasis on here? Okay, refers to irreversible abnormal dilation and thickening of the bronchi that results from recurrent infection and chronic inflammation. Patients typically present with frequent cough, excessive sputum production, and frequent respiratory exacerbation. Narrow and obstructed airways result in wheezing and pulmonary auscultation. Patients often have a history of recurrent episodes of pneumonia in childhood and adolescence. Conditions associated with bronchiectasis include chronic bronchial obstruction, tobacco use, cystic fibrosis, primary immunodeficiency, Carcinoid syndrome, ABPA, aspergillosis. CT scan of the chest can confirm the diagnosis, and pulmonary function test will show obstructive pattern. Management consists of identification and treatment of the line disorder, airway clearance technique like this, your chest physiotherapy, expectorant bronchodilators, and antibiotics for acute exacerbation. It's not smoking story can play a role in development of bronchiectasis by inducing inflammation and chronic irritation. Patients who smoke are more likely to develop COPD and bronchiectasis. This patient has 25 pack years smoking history and quit 15 years ago, making smoking history less likely to be the major contributor. Next.
A previously healthy 22-year-old woman comes to the physician because of 2-month history of intermittent moderate headache. She is otherwise asymptomatic. He no medications. Takes no medications. He has smoked 1 pack of cigarette daily for 4 years. Her temperature 37.6 degrees Celsius, pulse 64 per minute, respiration 18 per minute, blood pressure 156 by 90 millimeter of mercury. Cardiopulmonary examination shows no abnormality. Mm. On abdominal examination, bruit is heard in the left upper quadrant. The remainder of the examination shows no abnormality. Serum studies show sodium 147, potassium 2.8, chloride 110, bicarbonate 32, urea nitrogen 26, creatinine 1.8. Which of the following additional serum finding is most likely to link within this patient?
Okay, so let's remain go behind. Oh, okay.
Ready?
Yes. Mm, it is angiotensin 2. Yeah, angiotensin 2. Renal artery stenosis is a cause of secondary hypertension because of the abnormal stimulation of the juxtaglomeralar apparatus from low afferent blood flow, leading to excessive production of renin and angiotensin. There are two main causes of renal artery stenosis: fibromuscular dysplasia and atherosclerosis. Young patients, such as this one, fibromuscular dysplasia is the more common cause, while old patients, renal artery stenosis, commonly due to atherosclerosis, due to activation of the RAS and high concentration of angiotensin 2. Secondary hypertension develops. Angiotensin 2 also leads to increased sodium reabsorption and aldosterone released by the hmm, sodium reabsorption in the renal tubule, aldosterone released by the adrenal cortex with subsequent increase in sodium and fluid retention. and hypokalemia. Vasopressin release from the posterior pituitary leads to increased fluid retention, enhance adrenergic function through inhibition of norepinephrine reuptake in the sympathetic nerve ending and stimulation of hypothalamic nerve center. This patient has hypernatremia hypokalemia due to increased angiotensin II concentration. On physical exam, a brim may be auscultated on the side of the renal artery stenosis. In urinalysis is typically normal. Diagnosis is established with renal artery Doppler ultrasound or MR angiography. Treatment includes angioplasty or stenting of the stenosis renal artery to improve flow. ACE inhibitors can be considered for unilateral renal artery, but can lead to AKI in the setting of bilateral stenosis. It's not B or C. ACE activity primarily exists in the lungs and plays an important role in the RAS system, which is responsible for regulating blood pressure via vascular tone and sodium fluid balance. ACE converts angiotensin 1 to angiotensin 2, which causes vasoconstriction and promotion of aldosterone and anti-ADH release, while some causes of secondary hypertension and fibromuscular dysplasia are due to increased ACE activity, is not the most common cause. Most common and likely cause of secondary hypertension in fibromuscular dysplasia is increased angiotensin 2 concentration due to increased renin activity from not from increased conversion of existing angiotensin 1. Angiotensinogen, Angiotensinogen is produced from the liver and is converted to angiotensin 1 by renin. In patients with fibromuscular, there is excessive production of renin and angiotensin. Excessive production of renin will quickly convert angiotensinogen to angiotensin 1, making angiotensinogen concentration low. Hmm, okay. Okay. We are done with this block. I'm gonna take a quick break so I can
Okay.
have my breakfast. Okay.